Welcome to the Osteoarthritis Action Alliance Lunch and Learn for July 20th, 2016. My name is Kirsten Ambrose, and I would like to thank you for joining us today. I'm pleased to introduce our presenter, Crystal MacKay. Dr. MacKay is a Postdoctoral Fellow at Toronto Rehabilitation Institute at the University Health Network in Toronto, Canada. She received her PhD from the Institute of Medical Science at the University of Toronto and a Master's of Health Science degree in Community Health and Epidemiology, also from the University of Toronto. She is a physical therapist and has worked in the field of arthritis research for over a decade. Her research interests include understanding the healthcare needs of people living with chronic musculoskeletal disorders, particularly osteoarthritis, and their health service gaps and the effectiveness of interventions for this population. We're also excited that she's joined some of our efforts here at the OA Action Alliance, so we're pleased to have her today. Dr. MacKay will share today. She will tell us about some of her research using focus groups and interviews to explore the perceptions and experiences of adults aged 35 to 65 years with mild to moderate knee OA symptoms. Welcome, Dr. MacKay.
Thank you very much, Kirsten. Good afternoon, everyone, and thank you to the Osteoarthritis Action Alliance for giving me the opportunity to share some of our research with you today. But today I'm going to be presenting research from a qualitative study of the perceptions and experience of adults aged 35 to 65 years with knee OA symptoms. And this research was conducted as part of my doctoral work at the University of Toronto. So I'm going to highlight some of the key findings from the study, as well as discuss some of the clinical and public health implications of the research findings. So as probably all of you are aware, OA is a highly prevalent and costly chronic disease that affects about 30.8 million people. It's also a leading cause of disability and healthcare use worldwide. Individuals with OA can experience pain, activity limitations such as difficulty walking, climbing stairs, getting in and out of a chair, as well as fatigue, poor sleep, and a lower health-related quality of life. But OA can also affect mood, social and recreational activities, and work participation. Now, historically, OA was often viewed as a disease of the elderly or just part of getting older, and research and clinical practice has often focused on older adults. However, I would say more recently, increasing recognition of OA in younger adults. The incidence of OA increases exponentially in adults aged 20 to 50 years. Half of people with symptomatic knee OA in the U.S. are diagnosed by age 55. And risk factors such as obesity and knee injury are on the rise and likely to affect the incidence of knee OA in younger adults. We also know that rates of total joint replacement. So as I was saying, the rates of total joint replacement are increasing in younger patients, and the fastest growing age group is actually those aged 45 to 54 years. In fact, there was more than a 300% increase in rates of joint replacement in this group in a 10-year period. The largest economic costs of OA are in adults aged 35 to 65 years of age, and that's accounted for mainly by long-term disability. So there's no cure for OA, but there are evidence-based strategies such as exercise and weight loss, which decrease the pain and disability. But to date, at least in Canada, the interventions and programs for younger people with knee OA symptoms are scarce. There's a need for interventions to reduce the pain and disability of knee OA in younger adults with earlier symptoms. But we found that there was a gap in understanding how younger people perceive, experience, and manage knee symptoms to even begin to develop interventions which might address these people's needs earlier in life. And prior research has shown that the perspectives of people living with illness are important for service development in the healthcare sector. So in response to this gap, we conducted a qualitative study of adults aged 35 to 65 years with knee symptoms to explore the meaning of knee symptoms to people, the consequences of symptoms on people's lives, and how they approached management of their knee symptoms. Now, before I continue, I'd like to spend a moment discussing the Canadian healthcare system, since that's where the study was situated, was here in Toronto. So in Canada, the roles and responsibilities for healthcare are divided between the federal and provincial or territorial governments. The but the provinces or territories have most of the responsibility for actually delivering health and social services. The healthcare system does provide access to universal comprehensive coverage for medically necessary hospital and physician services, but funding for other services such as care by other professionals, for example, physical therapists, are at the discretion of the provinces or territories. So some services people will have to access through their private health insurance or pay out of pocket. So the study sample for our study were people aged 35 to 65 years of age, and they had to report a diagnosis of knee OA or that they had knee pain, aching, and or stiffness on most days of the past month. And we did this because we felt that some people who are younger may not perceive their symptoms to be OA or have a formal diagnosis. Exclusions were made to ensure people were more likely to have knee OA symptoms. So we excluded people who had a knee injury in the past year, knee pain referred from the low back, other types of arthritis, those who had been recommended, were waiting for, or had joint replacement, and those who had chronic physical health conditions affecting their mobility other than OA. So we sampled purposefully to try and ensure that we had both men and women who varied in age across our age group. Again, it was we recruited participants from the Greater Toronto area and collected the data using both focus groups and one-on-one interviews. So here's the demographics for the study sample. We had 51 participants. This included 6 focus groups and 10 one-on-one interviews. And I'd just like to highlight on this slide that the median age was 49, ranging from 37 to 65 years of age, that 60% were female, that it was a fairly highly educated group of almost 60% being university educated, and almost 80% of the sample were working, which is probably not surprising given the age group. I'm going to now turn to the key findings from 3 papers which address the research objectives. So first, how did participants perceive or understand their knee symptoms? So the core category, or what the central theme of the data, was that a perception that symptoms were preventable, meaning that there was potential to prevent the onset of symptoms and alter the course of symptoms. This was demonstrated in how participants explained their symptoms. They commented on the cause, prevention, and course of symptoms, and they often reflected on their experience with symptoms, indicating that symptoms made them feel older than their current age. However, they did not perceive their symptoms as normal or acceptable. So I'm going to walk you through each of these. So participants explained the cause of their knee symptoms by often recounting their personal histories, relating their symptoms to prior actions or incidents, or their personal characteristics or family history. The common across accounts was at least partial attribution of cause to action or incidents which were modifiable, and rarely did they attribute the cause solely to aging. They also believed the course of symptoms could be modified or controlled, at least to some extent. And this was illustrated by Samantha, and I will say that all the names I use here are pseudonyms. And she was speaking about exercise. She said, "I know eventually that will happen, surgery, but the exercise that I'm doing now will probably keep it at bay for a little while." And in linking their symptoms primarily to actions or incidents, some participants believe they could have prevented the onset of symptoms had they changed their behavior earlier in life. So some participants indicated that had they not engaged in high-impact activities or reduced the extent to which they performed activities or avoided injuries, they might have prevented their symptoms in the first place. Now, Chada was one of our older participants, and he was reflecting back on life and commented, "What should I have done different? I would have stopped jogging. I would have gone more on a bike. It was nice at that time, but there is a payback." So participants also expressed that the changes they experienced in their physical abilities due to their knee symptoms made them feel old. They suggested that their physical symptoms drew their attention to their age. It was particularly common for adults in their 50s and 60s to reflect on aging. However, the participants did not normalize their symptoms. And here are 2 quotes that illustrate how people felt. The first one was by James, who was 42, and it was following a discussion about how young he felt when he was running. But after having to give it up due to his knee, he stated, "It's like I've aged 20 years. And the second quote was from Audrey, who said, "In my mind, when I was this age, up until I was 90, I envisioned myself continuing to play tennis, continuing to ski, all these things that I like to do." So the consequences of knee symptoms. Now, the main theme explaining the consequences of knee symptoms was disruption and change. Now, in this diagram, what I'd like to highlight is that there's two main categories of disruption and change: a disrupted physical, emotional, and social life, and an altered way of thinking about the body and self. All these consequences were interrelated, and the person's context, such as their gender, age, a stage of life, the nature of their social roles, all shaped how people experience these consequences within their lives. Again, I'll walk through each of these categories of disruption and change. So participants often reported that knee symptoms affected their physical activity. They often gave up high-level activities such as sports, running, or hiking, or changed how or how much they performed these activities. So for some participants, changes in physical activity represented a real loss of valued activities in their lives. And these findings are illustrated here by two quotes. The first was from Mark, who said, "I ran almost 7 days a week for a good 10 years, pretty much 5K a day every day, and there's nothing more in the world that I like more than doing that, and to have it cut off like that." And the second quote was from Adam, who said, "I may not be able to do them, the activities, to the extent that I did them before." There were also changes in social life, including leisure, activities, family, and work life. So in particular, when people engaged in physical activities that were part of their social life, they were more likely to report a disruption in social life. So Susan reported, "I have a couple of girlfriends who are walking regularly, and then I really hurt my knee bad and I couldn't join them. I'm socially isolated because of it." But participants also reported disruption in family life, particularly as parents of younger children. They expressed challenges in playing with their children, like getting down on the floor or engaging in sports with them. Only a few participants actually gave up or changed work due to their knee, but many reported adapting their work environment, the way they performed the job, or the hours they worked due to their knee symptoms. Participants also expressed emotional disruption. They commonly expressed frustration and annoyance at having to deal with symptoms and the consequences on their lives. But they also reported depression, as illustrated by this quote. "I was running and very skinny, so it's caused a little bit of depression trying to manage everything, not being able to do everything that I used to." Participants also expressed an altered sense of self, so they described changes in the way they viewed themselves. Some participants' view of themselves in particular roles changed. And for example, Rebecca talked about being a mother, and that's that first quote. She said, "I'm a bad mom because I can't look after my kids the way I want to." But others talked about the physical changes which made them feel they were no longer infallible. Men in particular recounted that they once felt strong and capable, but knee symptoms made them feel less capable. Some women also reported that symptoms undermined their view of themselves as active and independent. Participants also often talked about having a new awareness of their knee. Universally, they recall not thinking about their knees at all prior to having symptoms, but after the onset of symptoms, their knee came to the fore of their consciousness, and they were very aware of having a knee. They often reported that their knee always seemed to be on their mind, and that they were very deliberate and cautious in moving their legs and thinking about if and how and when to perform movements. And this is illustrated by the quote from Gail in the middle of the slide, who said, "I'm constantly aware, thinking twice with every activity. Everything now has a new think to it." And there was also a lack of trust that people expressed in their knee. So they recounted unpredictable symptoms of pain, giving way, even locking. But as a result of that lack of control, they reported they often didn't trust their knee. And this was illustrated by Donna, who said, "If I was coming home and it was dark and somebody was following me down the street, could I feel out of here? Could I trust my knees to do that?" I'm going to move on now to talk about the management of knee symptoms. And the core category which explained management was taking action on knee symptoms. And this diagram illustrates the active process by which people work to control their knee symptoms and disease progression. They often responded to their knee symptoms by seeking solutions. And in some instances, participants found strategies they perceived to work, and then they would incorporate them into their ongoing management or use them as needed. But it really was not an orderly or linear process. Rather, people moved back and forth between looking for something that might work and actively managing their symptoms. Again, I'll speak a bit more to each of these themes. When people were seeking solutions, they often tried a range of strategies such as exercise, weight loss, creams, medications, to name a few. But they engaged in a process of informal learning. So they were doing their own research. They consulted the internet, magazines, books, and they often talked to peers with knee problems. So here's a quote from Peter who said, "You get it from people who know, like, I don't believe anything until I hear it 3 times." But participants also engaged in a process of trial and error. And this was illustrated by a quote from Debbie who said, "I want to lose 10 pounds in the next 4 months, and then we'll look at that and see, does that play a part in it?" Now, most participants in this sample did seek help from healthcare providers. They often consulted a range of providers, including their primary care physician, and some sought help from physical therapists, chiropractors, and other professionals. Some of the younger participants in the sample expressed frustration that their concerns were not taken seriously and they struggled to manage. And other participants conveyed that they perceived that there were very few limited medical options for them. And that's a quote from Nigel, the first quote on the slide that says, "You know, the allopathic medicines, the Celebrex or Vioxx. As a Canadian consumer, what are my choices?" Participants also perceived that they had received inadequate guidance and support. So, for example, Tiana was diagnosed with early knee OA, and she wasn't clear what to do. So here's a quote from her. She said, "I guess what I'm really frustrated with is my physician has not really given me any direction as to what could I do or shouldn't I be doing." So some participants did use strategies as part of a regular routine of health practices or on an as-needed basis. And that was illustrated by Ken, who said, "I made a conscientious effort to do 3 times a week an exercise regimen more consistently." But participants did report that management was hard to maintain, it took time, and often it took money. Some strategies were used only temporarily, and then the search for new solutions resumed. So management was really viewed as a never-ending process of trying to find solutions and maintaining active management. So in summary, participants viewed symptoms as often as potentially preventable. They made efforts to manage symptoms, and this involved a complex process of searching for solutions. Participants with knee symptoms described a myriad of significant consequences on their lives, and they often perceived that medical care offered limited options and guidance to younger people with earlier symptoms. I do want to point out a couple of limitations with the study. So we did use a self-report diagnosis of knee OA or chronic knee symptoms. However, this was a well-used survey question on knee symptoms, and we did try to use careful exclusion criteria to get at people more likely to have knee OA symptoms. And I'd also just like to highlight that the sample was well-educated, employed, and living in an urban environment. So what did we learn from doing this study? I think it does provide us with some insight into how younger adults perceive and experience knee symptoms. We did find some differences compared with prior research, which has been conducted mainly in older adults, often over the age of 65. So, for example, study participants perceived knee symptoms as preventable rather than an inevitable part of aging, which has been found previously in studies of older adults. And the findings also highlighted some of the unique consequences experienced by adults aged 35 to 65 who are often working and may have younger children. But overall, the findings suggest that there may be an opportunity for earlier intervention to provide guidance and support to adults aged 35 to 65 years who are experiencing knee symptoms. So I'd like to highlight some potential implications. So first, from the perspective of clinical care, I think there may be an opportunity to improve self-management support for younger adults. I know to date in Canada that self-management support is not routinely integrated into primary care, and self-management programs may not be accessed by younger adults who have knee OA symptoms and may not yet have a formal diagnosis of OA. I think there's also opportunities to improve support for physical activity and exercise in primary health care in the community. Changes in levels of physical activity at relatively young ages may have consequences on health and well-being, and there may be need for support to remain active in valued activities throughout their life. Participation in physical activity and exercise we know can reduce pain and disability of knee OA, and it may also reduce the risk for comorbidities in the future. I think findings also suggest a need to tailor advice to individuals' needs, considering the range of consequences that they experienced and within the context of their life. So considering their stage of life and the nature of the roles in their life, such as the work and family. It also suggests we may need to consider how to provide ongoing support over time, since management of chronic condition like OA is hard work to maintain over the course of a lifetime. And finally, with respect to public awareness, I think the findings indicate there may be a need for enhanced public awareness of OA around the early signs and symptoms, and maybe just promoting that message that OA is not just a disease of older adults. Before I conclude, I'd like to acknowledge my doctoral supervisor, Dr. Aileen Davis, my program advisory committee members, my funding sources, and of course the study participants who so graciously gave me their time. So I'd like to thank you, and I'm happy to take any questions at this time.
Thank you, Dr. MacKay. That's definitely some interesting information. We haven't heard as often from this population of younger adults who have OA, and I think they're a growing population. And you noted an interesting shift in the mindset of the younger generation. You stated towards the end of your talk that they saw this as preventable and not inevitable, which has, I think, been the classic feeling about OA that is changing. It's nice to see that that seems to be, that perception is changing in the younger adults, and hopefully, as you stated at the very end, we can put some emphasis on early detection of symptoms, early detection of signs and awareness and that sort of thing.
Mm-hmm. Thank you.
So we have our chat window down there in the lower right corner of the window for anybody who is interested in asking a question. It looks like we have a few people who are typing in. First one came in. What specific monetary issues were related to the younger adults? Loss of income due to the adaptations?
Yeah, thank you for the question. I think that some of the extra costs were actually that people were sometimes paying out of pocket to try different therapies. So sometimes that might be seeing a healthcare provider who they needed to at least pay for some of the services, even if their insurance covered some of it. As I said, things like physiotherapy is not always covered, and certainly chiropractors, naturopaths, and some of the other providers people would be seeing if they weren't covered by insurance, they would be paying for that. But also people talked about, they might have tried going to the pool or the gym or other things that they also had to pay out of pocket for. Loss of income was a factor for a couple of participants who had to felt that they had to give up their jobs due to the symptoms. They were people who had more physically demanding jobs. They were the minority in the sample, and I think that's probably related to the fact that there weren't as many people who were doing jobs that involve more physical labor. That might actually increase in a different sample.
Thank you. I'm going to come back to that next question that's down there, but the following one, should we do more when talking about OA? Should we address the precipitating causes?
So I think that we could do more, if I'm understanding the question correctly, potentially about talking about the risk factors for developing knee OA, particularly in younger people. I mean, there's sort of growing post-traumatic population developing knee OA, and perhaps we could be thinking about talking more about the risks of developing that with that sample that we know are at really high risk of developing knee OA, and I'm not sure that routinely happens within the healthcare system. And certainly I think there's a role for more primary prevention and knee injury prevention programs, and with all of the other reasons we need to combat obesity, that we could be doing more about that as well.
And were there any particularly helpful online resources or websites that patients mentioned were useful or helpful?
That's a really great question. Off the top of my head, I can't recall any particular resources that people mentioned that really helped them. To be honest, They often talked about getting information from peers or other people, but they didn't. I don't really have any recollection of specific websites, for example, or resources that they mentioned that stood out to me.
Well, we can start sharing the OA Action Alliance resources.
Yeah, absolutely.
I was thinking about that when you responded to the prior question about our need to pay attention to obesity and injury prevention, and those are a couple of areas that we are focusing on. So key for primary prevention, certainly.
Absolutely.
And then the question that I skipped over, any discussion of role of regenerative therapies as they pertain to NEOA?
There wasn't actually a lot of discussion in this data about that. That I recall, actually, no. And people had a lot of, were addressing or asking questions about what kind of therapies might be available in the future and things, but that specifically, it didn't come up that often.
Well, and one of the reasons that I skipped over that, we are, for a couple things, we're coming towards the end of our webinar here, so in giving the announcement for next week's webinar, I'll put it up here in the chat box. At the Alliance, we are very focused on behavioral interventions and self-management, physical activity, those kinds of management strategies. But the steering committee chair for the Alliance, who is a sports medicine physician at Drexel, will be speaking to us next month on viscosupplementation injections for NEOA. So a different kind of therapy option for people that are interested in that route. So, well, good. If there are no more questions, I wanted to thank you, Dr. MacKay, today for a very interesting talk and for your time, and to all of our webinar participants for their time, and hope that you'll keep up with the Alliance and keep up with all the good work that Dr. MacKay is doing.
Thank you very much.
Thanks, everyone. We'll see you next month.